We get 700 to 800 urgent skin cancer referrals a month. That's expected to go up by 10% year on year.
You just haven't got enough dermatologists to see all of those patients.
It's just kind of a recipe for disaster. So we do need to start thinking differently.
So for us, as a medical device that has a regulatory clearance, that enables us to make management decisions off the back of what the AI says.
I think firstly, people think, oh, AI is going to replace me. I'm not going to have a job. I think we can all safely say that there is enough work for us all. So certainly we can probably get up to 20% of our referrals being discharged by derm. And it's just all about increasing our capacity, which increases our time to do other things and do the right things. I really hope that as a body, we can really start to embrace new technologies and how that can improve the services for our patients.
The mission is trying to build a world where no one dies from skin cancer, because early diagnosis really does offer that opportunity.
There is a lot of opportunity.
So much opportunity.
Today, I'm joined by Dr. Dilraj Kalsi, Clinical AI Lead at Skinalytics, and Dr. Alice Plant, Consultant Dermatologist at University Hospital, Dorset. Today, we're going to be talking about dermatology, AI. What are some of the challenges? What are some of the opportunities? Where are we now? And what does the future hold? So let's kick things off with some introductions. So Dilraj, could you start telling us a little bit about yourself? And for those who aren't familiar, Skinalytics.
Yeah, thanks. So thanks for the opportunity to be here today. So I'm Dilraj, I'm a medical doctor by background. In that time, I've sort of spent a decade involved in health tech, but gradually more and more moved into it. And then for the last 4 years, I've been at Skinalytics as our clinical AI lead. My primary responsibilities have been focused on the real world evidence. So like the patients that we are seeing in the real world and have been assessed by our AI, what's happening to them at the end of their journey, and how does that marry up with what the AI assessed at the front. The company, Skinalytics, is actually over a decade old. There's a lot of groundwork that's gone into where we are now. The mission is trying to build a world where no one dies from skin cancer, because early diagnosis really does offer that opportunity. And we're really leveraging AI as a medical device to create pathways where patients can get better outcomes. And I think broadly speaking, I think it applies to all AI, but the notion of trying to prioritize patients and how they're seen at the right urgency and making sure that that marries up with how dermatology capacity is distributed is really what we're trying to support to better those outcomes.
Brilliant, thank you very much. And Alice?
Yeah, so my name's Dr. Alice Plant. I'm a consultant dermatologist at University Hospitals Dorset, which is the relatively newly merged Bournemouth, Poole and Christchurch Hospitals Trust. So we're down on the south coast. I have been a consultant there for almost 3 years and did my dermatology training in the Wessex region, which includes Portsmouth, Southampton and Dorset. And one of my roles as a consultant is a digital lead, and hence the Teledermatology lead within our department. And that's when I've become involved with skin analytics. And we can probably talk about that a little bit more.
Absolutely can. And before we delve into that, should we have a chat about the state of dermatology services at the moment? And Dilraj, are you happy to touch on that from a national level?
Yeah, for sure. So there's quite a lot of, I think actually it's worth acknowledging the UK for how good we are at monitoring what's going on in our services nationally, in particular with regards to skin cancer. You see in most countries they'll monitor what's going on in terms of melanoma, but not necessarily non-melanoma skin cancer. So credit to our systems for doing that. But unfortunately, what it does show is that there's a growing referral volume from GPs into secondary care of urgent suspected skin cancers. That's going up 10% year on year. And that's on a backdrop of there not being enough consultant dermatologists. So 1 in 4 consultant posts are not filled in the country, which means you just haven't got enough dermatologists to see all of those patients. But even in terms of what those referrals and how they're distributed looks, unfortunately, we've got 1 in 3 of your melanomas and squamous cell carcinomas, the high-risk skin cancers that are meant to be on that urgent pathway. They're found outside of it. And so when you've got these urgent skin cancer referrals, which have to be prioritized and naturally get prioritised over other clinics, but you've still got cancers waiting to be found in other pathways, there's a much greater risk of delayed diagnoses for those other patients. And that's before we've even started talking about the inflammatory disease that dermatologists need to see and manage. And when you get those longer and longer wait times, there's a lot of patients with deteriorating quality of life in the meantime. So as much as our focus is on trying to support that skin cancer referral volume problem, actually there's a broader ramification in terms of what we hope to support with from a dermatology capacity point of view.
Absolutely. And do you think it'd be fair to say that there's not going to be, that you couldn't train enough, that there's not going to be capacity for enough doctors or people to be able to achieve the capacity that is required?
Yeah, it's a really good question. So I think the short answer is just know that like the years of training, and Alice can speak to that's required to make up a shortfall like that is substantial. And there's been lots of different potential solutions that have been tried over the last decade, trying to train GPs in dermoscopy, trying to do teledermatology on its own, and sort of insourcing sort of private waitlist kind of clearing initiatives. They're not necessarily, I mean, the GP training one would be ideal, but they're just so stretched, and we all kind of see that impact in our day-to-day lives, like not even being able to get appointments. And even when we've worked with GPs on the ground, you can sort of see in the quality of the images that they capture that they are in a rushed appointment and they just don't have the bandwidth to do this. So I think unfortunately, those solutions alone are not going to make up that amount of shortfall on a kind of growing referral volume. And there's as much as that referral volume's growing, the targets that are set for GPs for any type of cancer referral is sort of a 3% threshold of them actually being cancers by the time they've been diagnosed. In skin cancer, it's around about 6% at the moment. It's been between 6 and 8% over the last decade that actually result in those melanoma and squamous cell carcinoma diagnoses. So it's not actually that bad compared to what target they're given, but equally that means that this referral volume is just not going to go down anytime soon because they're not incentivized to do any otherwise. So yeah, it doesn't feel a very sustainable picture, and unfortunately you can see the trend lines are not going in the direction that we want them to. So I think there does need to be capacity built from new ways of working.
And Alice, can you speak to that from your experience?
Absolutely. So locally, we've seen an absolutely burgeoning demand from a skin cancer perspective. So in Dorset, we have a demographic, which means that the average age is probably slightly older than the rest of the country. So we have a lot of type 1, type 2 skin types. So those are your paler skin types. We have a lot of skin cancer around. And as Dilraj has said, the diagnoses of high-risk skin cancers, being your melanoma and SCC, is increasing year on year at an estimated 10%. So most months we get probably 700 to 800 urgent skin cancer referrals a month, and that's expected to go up by 10% year on year. We have, as a local department, looked at various ways to meet that demand by using super clinics. We even have the top floor of an old shopping centre that we use for these super clinics, and we in the past have really tried to increase our capacity and efficiency for getting through the numbers, but with such a demand without increased staffing levels. And really that comes down to training numbers. So historically, after you've done some of your training as a junior doctor, you then apply for a specialist training number in a specialty. So in my case, that was dermatology. Those training numbers, they're not increasing because as a whole, as a workforce as a whole and workforce planning, we need more people in acute hospitals and we need more GPs. So it's not going to be anytime soon that we get more of those training numbers. So if you're not training as many dermatologists, we then have looked at doing something called the CSER pathway, which is for doctors training in a specialty locally, and so we have a few of those in within the area to try and increase that. Locally, we use a lot of our nursing staff. We've got excellent specialist trained surgical and skin cancer nurses to help with this demand. But all of this in combination just can't compete with that increased demand. Now, locally, actually, our GPs are pretty good if you look at the national average of their conversion rate. So that's how many of the urgent suspected skin cancer referrals actually are skin cancer. And they are pretty good. So I think it's supposed to be about 6 to 7%, and it's about 10 to 11% locally. So they are doing a good job. But we are now seeing that with the increased pressure in primary care, more and more allied healthcare professionals are being used as that first point of contact for patients. And they simply do not have, GPs don't have much training in dermatology. Then adding in these allied healthcare professionals, they don't have any training in dermatology. So we're finding, and this is very much from a secondary care point of view, but we are finding that a lot more of our referrals are coming from them, and they are not necessarily the most appropriate referrals. But that's just a symptom of the struggling primary care service. So all of this together, so you've got this increased demand because there's more skin cancer, you've got fewer trained staff within the primary care, and then not enough staff within secondary care is just kind of a recipe for disaster. So yes, we have in the past tried to think outside the box, but I think as a nation within dermatology, we are recognising that we do need to think very differently if we are going to be able to provide services to the patients who most need it, and that comes back to that right patient at the right time being seen by the right person. And so we do need to start thinking differently, because as Dilraj mentioned, so skin cancer referrals are probably about half of our workload. We have our inflammatory patients who are really suffering as a result of all the national targets being on skin cancer diagnosis, rightly so, but those inflammatory patients, so those are people with severe eczema, psoriasis and other rashes, are not getting good care. Locally, they are waiting up to 18 months for a first appointment with a dermatologist, and we are having to really strip back some of the treatments that we can offer for those patients just to try and meet the skin cancer demand.
That paints a pretty stark picture of the current state of dermatology services. And I guess it leads on quite nicely as well to the opportunity for technology. Where is the opportunity for technology to play a role here, and specifically in dermatology?
So I think to that broader question, there's always going to be potential opportunities across the whole patient journey and across a whole set of workflows in that, whether they go from the administrative and booking appointment side of things through to when you're making clinical decisions and what information you need at the time of. But yeah, the biggest thing, I think, and particularly in the context of that burden that we've talked about, is that we just need something to shape how much volume and manage that volume of patients better, whether that's more appropriately routing the level of urgency that they're seeing, or being able to actually reduce that. And so for us as a sort of medical device that has a regulatory clearance, UKCA Class 2A, and more recently CE Class 3 across Europe, that enables us to make management decisions off the back of what the AI says, that we can say this patient doesn't need to be seen and they can actually be discharged from the pathway. And that offers an opportunity of sort of, across our pathways, you see about a third of patients can come off these urgent skin cancer pathways. It will vary according to local incidence. So in a population where Alice works, where there's a bit of a higher incidence of skin cancer, it's a bit lower than that. But that really does offer there aren't any other opportunities that I've seen to actually reduce the case volume as a whole. And then there's opportunities within the remaining caseload to say, these ones should be seen more urgently, or these ones should be seen less urgently. And so we'll continue developing in that way, that we keep working on that right patient, right person, right time, leveraging the AI output to get patients where they need to go.
Yeah, and to build on that, can you talk about how this looks in practice, how your technology works in practice to...
Yeah, for sure. So what we'll have, if we just describe what the pathway looks like at Dorset as an example for now. So you've got patients who've been referred by their GP on the urgent suspected skin cancer pathway. They will go to a location. It could be in the community, it could be in the hospital. It depends. We try to make it as accessible as possible, depending on where our partners can get the estates to run these pathways. And then they'll be met with a medical photographer, healthcare assistant, or a nurse, an allied healthcare professional who will do some training with. Our transformation team will work with them on that. They'll have some asynchronous resources as well that we've worked on with some people from some senior medical photographers before. And so they'll capture all of the relevant medical history, all of the relevant history about those moles, those lesions, on a pro forma, on a web portal. But then they'll also capture macroscopic and dermoscopic images of the lesion. And those dermoscopic ones are what are assessed by our AI, which is called Deep Ensemble for the Recognition of Malignancy. It spells derm. Yeah, that's obviously a long name, and I've learned that one for today. But yeah, so the idea is that these dermoscopic images are captured and they'll be assessed, and they have to be captured using specific combinations of hardware. Typically, it's a smartphone and dermoscope attachment combo. Normally, we'll use an iPhone 11 and a Dermlight DL1 basic dermoscope, but that's really trying to make that image acquisition as accessible as possible. And then it can stratify those lesions into the level of urgency that they should be seen. But it has a 3-step process to do that. So it first confirms that the type of image is the right one, that it is dermoscopic, not macroscopic, or not of something else entirely. It confirms that it's the right quality, so it's not too dark or not too blurry and can be assessed. And then it will classify the lesion type. And so what it can output is all of the most common malignant, pre-malignant, and benign lesion subtypes that you would see. And then we'll twin that up with what the management outcome should be in the context of that pathway. So in the context of the pathway we work in Dorset, you've got someone who has been put onto this urgent pathway, and we're trying to discharge the ones that are benign. Any of those benign outputs are linked to a discharge or routing towards discharge for those patients. All the remainder in Dorset's pathway will be reviewed via virtual dermatology or teledermatology review, which is what Alice will do on that side of the pathway. There are other models where we're sort of in pre-referral. There's an opportunity to also, where patients are suitable for an AI assessment, instead of seeing their GP, they can go to a community hub location, have these same sorts of images and history captured, and then have the AI determine whether they need a referral and what urgency that needs to happen at. And then there's the same opportunity to use the same information in those urgent referrals, or the ones that do need to go to the dermatology services in the trust, to have those virtual reviews. So it's a really connected pathway that we're looking to build across everything.
Thank you. And Alice, how does that differ from how things are done traditionally?
Well, I guess traditionally, going back pre-COVID, certainly a GP would see a patient and they would make the decision to refer on an urgent skin cancer pathway. So if they suspect melanoma or SCC or high-risk BCC, then that patient would come in on that pathway. So it used to be called a fast-track pathway, 2-week wait pathway, and they would be seen face-to-face for an assessment. Gold standard would be that we do a full skin examination. So certainly back in the day when I first started training, every patient who came in on that pathway would have a full skin examination where you would pick up other skin cancers as well. And then at that face-to-face appointment, you have the opportunity to discuss onwards management and do certain treatments as well, for example, cryotherapy, which is used for some pre-malignant conditions. And then that patient's seen a dermatologist and would then have a clear plan going forwards. They'd have to then come back on another day for their surgery if that's what they're having. I think it's important to note that probably, certainly locally and I think nationally, people were starting to use images. So certainly in Dorset, we had a period of time where we had one consultant dermatologist in one of the departments, and so nurses were used to take photographs and then have a virtual assessment at a later date. But those images weren't particularly of great quality and certainly didn't include a dermatoscopic image. So we've been sort of toying with teledermatology for quite some time, and already photographs are used in our advice and guidance pathway as a means of triaging non-urgent referrals. And then locally, as I mentioned before, we've been doing these sort of super clinics, so they're rapid access clinics, where a nurse will take a history, get the patient undressed, and then you'll have a consultant or specialist going in and out of multiple rooms just in an effort to increase that efficiency. So that was how things used to be. and certainly still is the suitable pathway for many patients, particularly those who do have multiple skin lesions that need to be looked at. But I think it's now moving forwards to try and realise that it's all very well giving the gold standard treatment to a few, but we need to be actually giving treatment to more patients now, and within the current capacity. Unfortunately, it means that not everybody can have a full skin examination, and that's probably where GP education needs to be improved, and maybe self-surveillance and improved just general population knowledge on skin cancer detection. But in order for us to be able to deal with the current demand, we need to sort of be thinking outside the box. And so with our pathway in Dorset, with the Teledermatology, the patients come in for an HCA-led appointment, where an HCA will take these images and they can take up to 2 skin lesions. And so part of the process and education has been changing our referral form, so a GP can make that decision as to whether that patient in front of them is suitable for teledermatology or not. So it does not disadvantage patients who need that face-to-face component. So if they're deemed to be suitable for teledermatology, the GP or referring clinician feels that that lesion can be accessed by a dermatoscope, because that's the key step. And actually, we don't necessarily, on that referral form, it gets a little bit confusing, but we don't necessarily have all the inclusion criteria for AI on that form, because there are still some skin lesions or skin growths that we can assess on photographs without necessarily the AI component of it as well. So we've tried to integrate those two. And then, yes, we, as a dermatologist, I then have a virtual clinic where I can get through at least double the number of patients I could in a face-to-face appointment. And I review those images with a clear history of the skin growth that the patients filled in prior to the appointment. And I can then either decide that I can make a diagnosis and then either discharge the GP with a management advice, or I can directly list that patient for surgery if that's what's required, or if I can't make a diagnosis, then I can bring them in for a face-to-face appointment still.
Moving on from that as well, how did this relationship with Skinalytics come about? And I guess the transition from this traditional service to where you are now?
So I think the pandemic brought about changes within the dermatology community as to teledermatology being something that we needed to think about, how it could augment our abilities. And so relatively early on in my consultant career, I was asked to look into a teledermatology pathway and how we could increase our efficiency, essentially. And then during that period of time, conversations were being had with Skin Analytics, and as a trust in combination with Dorset County, which is Dorchester, which is a little further west than we are, we were awarded a pilot year. And so that pilot year started in March 2024, and so we're just coming to the end of that first year of pilot of post-referral pathway, integrating the medical device derm into that teledermatology pathway. So we had a few months of a formal teledermatology pathway prior to integrating derm. So I guess where I, as a dermatologist, have seen its utility is increasing that discharge rate. So those patients that never come across my desk, and that because they are benign, and so I don't need to review them, to increase my capacity to be able to see the skin cancer patients that need me to be able to diagnose them and treat them. And then hopefully that will increase our capacity to see our inflammatory dermatology patients, which, to be honest, is where my interest lies.
And did you find that any of your team or yourself were skeptical about the potential of integrating AI into your work?
Absolutely. And that skepticism continues. I think when people hear the word AI, there is this automatic negative bias. I think firstly, people think, oh, AI is going to replace me. I'm not going to have a job. I think we can all safely say that there is enough work for us all, and that is not going to happen. And then there is understandable caution. At the end of the day, we are talking about somebody's health, and we are talking about a cancer diagnosis here, and that has a lot of emotion associated with it. Patients have been referred on a suspected cancer referral pathway, and I think sometimes as healthcare professionals we forget what a significant word cancer is, and they are therefore understandably concerned. So I think it's addressing both the patient skepticism and also the healthcare professional and management skepticism about this utility. It has a cost associated with it as well. And so understandably, there has to be that cost-benefit analysis, and we need to know that the money that we're putting into this is actually going to equate to an improvement in our service. I think anybody who's worked within the NHS knows that there is a, may I say, resistance to change. People are ingrained in the ways that things have always been done, and face-to-face remains gold standard. As a doctor, I enjoy that experience with the patient and getting to know a patient and going through that pathway. I didn't go into medicine to sit and look at a screen, but then again, you just have to think about the bigger picture. And I think that in a huge organisation such as the NHS, looking at change is always very difficult. I think one of the learning points from this year has been the difficulty of actually finding the correct key stakeholders within a hospital, and the flux that there is within management structures, and also changes politically with NHSE, ICBs, etc. And it's really difficult to find the right people and get the right people in the room to make decisions without deferring it to yet another committee. So I think there has been a lot of skepticism, there has been a lot of resistance to change, but it's acknowledging that everybody comes to change at different rates, and it is actually really helpful to have skeptical colleagues, and sometimes that just makes you sort of take a step back and make sure that something is done right the first time, rather than all guns blazing going forwards and then having something that doesn't actually do what we want it to be doing.
That's quite a remarkable perspective, to be honest. It's again, it continues to paint like a stark picture of the state of the NHS, and I guess decision making and integrating new technologies and change, but also for skepticism isn't, like you said, it isn't a bad thing. And have your perspectives changed on AI since you've been using, or in using these digital tools since you've had your pilot with Skin Analytics?
Yeah, absolutely. To be honest, I didn't have much of an insight into artificial intelligence, and I think it's certainly something that has really taken off within the last year, with everybody using ChatGPT, Copilot, etc. And I probably wasn't one of those. I'm still a textbook girl. I think I probably went into this not necessarily knowing so much about the AI and digital side of things. Well,
I guess also as a clinician or as a consultant, you want to see the results.
Yeah, absolutely. And you do go in with caution. And it's a very new skill. Analysing something just on a photograph without that ability to feel and to ask a few of the questions that you would sometimes ask is a very different skill, and you're taking on a significant increased level of risk, really. But I think it's coming back to really understanding what we want the AI to do and what we're asking it to do. We are not really asking it to diagnose. That's still really my job. What we are asking it to do is to correctly identify benign skin lesions, to therefore be able to give a timely reassurance to patients who are worried about their diagnosis, and also mean that my time is used on those people that need it. And I think if you're clear about what you're using AI or a medical device for, then I think you can probably address some of that risk in a different way, and it can be reassuring for you as a clinician.
And Dilraj, I guess from your perspective from Skinalytics, you've been involved with many different institutions trying to integrate your technology. And how have you overcome some of these challenges working with clinicians, patients, and trying to deliver?
I don't think that's ever not been part of what we need to be doing. It doesn't matter whether we've sort of got a long established partnership or it's a new one. I think there's, as Alice has alluded to, there's so many stakeholders involved in making these pathways work, and that can shift. New people can come into that who weren't familiar, and some of the same questions come up again. I think that there's quite a lot of sort of, from a company perspective coming into this conversation, there's quite a lot of market education that we have to do. There's so many things that sort of, particularly with that whole boom of people using LLMs, there's a lot of assumptions made coming into the conversation when you hear just AI. It's like just two letters, but you have all these things that you think about it when you come into it. And so those things don't apply to us as a particular AI as a medical device with a very specific purpose, with a ton of evidence and very high levels of regulatory clearance behind us. But that doesn't necessarily factor into the conversations, because they're not always data-driven conversations, actually, because these are emotional things that are at play, right? We're dealing with cancer patients. Cancer has a ton of stigma to it, and so we have to be sensitive to that at all levels of our organisation when we're dealing with anyone who's coming to join us in that journey, at any part of it. It's definitely a big challenge, but I think it's part of the adoption curve that we've sort of had to take on and take responsibility for. So, and I'd like to think we're doing a pretty good job of taking people on that journey in the right way.
Yeah, and how have you gone about developing your product to tailor towards these challenges?
Yeah, so I think it's an interesting one, because we're trying to focus our attention on what's going to add the most value from a systemic point of view, and that's not quite the same thing as the point of decision making that Alice has on that next step of the journey. We're before that trying to make sure that whatever comes to Alice's desk is the best use of her time. And so there can be sort of, because you could actually have an AI tool anywhere from that initial point of patient concern through to their final point of diagnosis, and they actually would have different optimizations. That's actually one of the things in terms of making sure that is well understood, that we're specifically in this point of the pathway triaging patients to the appropriate urgency, trying to reduce that case volume and focus of your attention, is actually quite a big potential point of misunderstanding, because it's not quite the same thing as everything that's focused on just supporting that dermatologist decision afterwards. That's not quite the same optimization as we're trying to safely rule out skin cancer and remove those patients. So, and again, that's kind of an intricacy of a specific AI as a medical device versus AI can do all of these things and we could apply it anywhere. And obviously we're sort of, we're medical doctors, we're trained to completely mitigate risks. And so as much as risks do exist, the way we practice day to day on the ground, you're managing that for yourself, and you control that in your own way. When you're then applying that kind of, how do I manage the risk across a whole pathway, where I might have to review patients in a different way that I didn't before, and there's this additional layer of a technology which I might have no understanding of prior to, is quite a lot for clinicians who are wanting to focus on that individual patient interaction to try and get their heads around. So Yeah, there's many layers of market education that we've had to do. I think there's lots of safety standards in the NHS for digital tools, the clinical safety ones, so DCB 0129, DCB 0160. I mentioned already the 2 medical device clearances that we have, but what that really means is that you've got independent bodies that have been, or notified bodies that have been asked by the medical device regulators to come in and look at our documentation, all of our quality management systems, including what's called the clinical evaluation report, which is a compendium of all our published and unpublished evidence. And they've gone through all of those documentations and said that you are approved to have derm assess dermoscopic images of patients with suspicious skin lesions and triage them and to their appropriate next management step, including that discharge step. So that's been available to us for over 2 years now, but that adoption curve has not necessarily been as fast as that would allow. And then we've got multiple independent evaluations that show that it's at least at the level of dermatologists in terms of safely ruling out skin cancer. One of the challenges is that there isn't really capacity on the ground actually to monitor how effective current practice is. So we don't have a great feedback loop on when a clinical service has missed a skin cancer and that patient's come back, certainly not at a population health level. But I think there's even a more fundamental thing where, in med school, I had 2 weeks of public health, of which some of that was stats. So even in terms of getting familiar with population health decision making, when you're thrust into a position of clinical lead for a service, is a journey that people have to go on. And that's like part of looking at the stats together and sort of making sure everyone's comfortable with that risk. You don't stare a risk of false negatives or miscancers in the face when you just change a workflow with the same clinical workforce. But in the context of a novel technology like AI, and we're on that relatively early part of the adoption curve, you have to have those conversations. And we've always done. It's essentially my job to find out what those outcomes were and make sure that everyone understands it. But it's one of those things that there's a lot of information to go through together within very limited pockets of time where you get to spend those times together. And they're quite significant decisions, but it's also got a background of other connotations of AI as a whole that that actually broadly don't apply to what we do and how we sit in the pathway.
And I think there's also an increasing frustration from patients and GPs that we're turning into a secondary care service that rules out cancer. And so what do we do with those patients who don't have cancer, but they've still got something that they went to the doctor with and needs treating? And it's how do we sort of integrate all of that in there as well? And we were talking about this earlier, and it comes away from this reactive healthcare service that we've got, which is treating the stuff that really needs to be treated. But what about all of the other stuff? So the pre-malignant and the benign lesions that we now don't offer removal of on the NHS. But as a population, and this is a bigger question, I guess, but as a population within the UK, we need to decide what we're happy for our NHS to be funding and to be doing.
And what's some of the rationale? I guess we could maybe start with some of the results that you've seen so far and where the decision making, what the rationale is for the decision making to decide whether to integrate these technologies.
During this pilot period, Dilraj might know the exact figures, but I think we've seen almost 2,000 patients through the teledermatology pathway. So we're not at, I think it's between sort of 35 to 45% of our referrals are actually going through the teledermatology pathway. And the reason why we're not higher is a lot of the things that we've already discussed, which is that resistance to change, that difficulty knowing longevity of something, staffing, job plans, etc. So certainly with that percentage going through the teledermatology pathway, we have been on an ongoing learning curve as to how to best utilise the AI to really optimise the pathway. I probably have been one of the clinicians who's done the large proportion of those virtual reviews alongside a few colleagues. And I think over time we've learnt a lot about how we use this new skill of teledermatology. So certainly we can probably get up to 20% of our referrals being discharged by derm. And we have an amazing patient pathway navigator that we managed to get through this whole pilot, who can then discharge those patients. So none of those cases come across my desk. And we've talked about ways that we can optimize that even further, and then how we can then further risk stratify some of these, so those pre-malignant and lower risk BCCs, to get them off of the urgent pathway, so that again, I'm using my time for the patients that really need it. So up to sort of 20%, we're managing to discharge without me having to see them. And then I'm in discussions with our sort of GP community as to whether we can be discharging some of the AKs and Bowens, so that's our pre-malignants, back into primary care or intermediate care for those to be managed, and some of those lower risk BCCs to go directly back to them for management. What other results would you like?
Do you have any to add to that?
So if you want the latest performance results across all of our sites, they're on our website, and we update them on a quarterly basis. The broad conclusion is sort of, if you look at the benchmarks for what dermatologists achieve in the literature, it's at least as good as that in terms of picking up skin cancers and safely ruling them out. That's the short story, and we've had probably, I think it's three independent evaluations and one that we procured ourselves that have come to similar conclusions. And then that broad health economic benefit from a kind of commissioner perspective of healthcare services is about £2 of benefit for every £1 of cost to implement.
And I guess it's probably important to say in Dorset at the moment, all cases are being seen by a second read. So a dermatologist does look at all of those, and we're looking at, with our governance team, how we can remove that second read, which has already been done elsewhere in the country. Because we are confident with the technology at being able to triage and correctly identify benign lesions. Within our trust, we've got 100% sensitivity, haven't we? So it's a pretty good tool, as in that just basically translates to, if a case is directed to me, it's very unlikely that if it's not directed to me and it's discharged, it's very unlikely to be a skin cancer. And clearly we have safety netting advice, etc. But it's just about increasing that conversion rate. So from those referrals that come into us, can that conversion rate be increased? So we've seen an increase of about 30%, so from about 10% up to 13-14% conversion rate. And it's just all about increasing our capacity, which increases our time to do other things and do the right things.
That's quite fascinating, and there's so many questions that could come out of some of the points that you've made there. I mean, firstly, the improvements in efficiency and taking away potentially 20% of the cases that you have to work on. That's quite a remarkable statistic. But I think beyond that, some of the challenges that you raised there about integrating a technology into a hospital and thinking about, for example, the longevity and wasting. These are some of the intricacies, I guess, of integrating technology into hospital care. Like, you don't want to waste time people learning something if they're not going to be using it.
Absolutely. And I think, so currently we're running what we call a post-referral pilot. So the photographs and the AI step is after referral, so it's in secondary care. So at the moment, we've still got patients travelling to a hospital site that might be one of our community diagnostic centres, the shopping centre. But still, we've got patients having to travel to that site to have a photograph taken. And understandably, there are frustrations from a patient perspective. Some are overtly positive about the whole process, but still elderly patients have had to make the effort to get to that site to have that photograph taken.
Whereas normally they'd go to their local.
So as normally they'd come in for a face-to-face and have a definitive outcome from that appointment. So absolutely, this needs to be in primary care. I think the process of having it as a post-referral in Dorset has been fantastic for us as dermatologists to be reassured by the technology, to get to know how it works. But at the end of the day, for this to have the impact that it needs to have and should have, these photograph hubs need to be in primary care. at the community level, so that the photograph is being taken in primary care. The patient at that stage is being determined whether they need an urgent skin cancer referral pathway. And then if we can integrate, shock horror, if secondary care could see the same stuff that primary care can see on the same IT system, then we could see those photographs, and I could still be doing the triaging, the direct listing to surgery, etc., that I'm doing, which will then have massive impacts on environmental factors as well, with patients not having to come for those face-to-face appointments, not having to pay for their parking, etc., etc. So there's so much capacity for this to be able to improve the whole pathway for the patient, not only through those things I've mentioned, but also just having that quicker response time as well.
There is a lot of opportunity.
So much opportunity. We just need people to fund it.
Yeah, and it's, I mean, that's a stark contrast from where we started the conversation. Of course, there are a lot of challenges that you touched on there, but the opportunity is equally as important. And there's a few key bits to touch on there. So firstly, what work are you doing at Skin Analytics looking at integrating into primary care? And is that something you're looking at? And then also, how do you manage post-market surveillance and making sure that this doesn't change, that the results that you're seeing, they remain consistent over time and you don't see drift?
Yeah, two very, very, very good questions. So we've had some funded pilots in that pre-referral model over the last year across 3 different ICBs with a view to evaluating this. Now, that one of the challenges is sort of getting a handle on referral rates and conversion rates. And the conversion and detection are a bit easier because we know what the end outcome is for those patients. But there's actually not very good data in terms of what GPs are doing, how many dermatology patients do GPs see versus how many they actually send on to the hospital, because GP data is not well coded. So that's something that an independent evaluation team at the University of Exeter are finalising their report on. So yeah, watch this space for that one to come out. But yeah, in terms of what we're looking to achieve, it's exactly as what we've described before, and we know that we're going to do a kind of dermatologist level sensitivity assessment as opposed to what GPs would be, which I'm sure there are many great GPs, but unfortunately across primary care, it's unlikely to be at anywhere near the level of what dermatologists can achieve in terms of detection. So the kind of aspiration for that model is to increase that conversion rate, ideally reduce that referral rate, but even if it was similar with a higher conversion rate, that's of value to the system. And the detection rate, which is essentially reflected in that 1 in 3 melanomas and SCCs are not currently on the urgent pathway, that's definitely going to improve in the context of deploying the AI in that earlier point of the journey. And then there's more opportunity, because at the moment, sort of, I think Alice's journey is a good description of this, that post-referral model is a lot more manageable to start off with. There's a lot of change. There's limited change management capacity in the NHS. And so when you have a hospital that's managing their front door, it's more of a contained system to get all the right stakeholders in play, make sure the patient journey is solid end to end. When you're moving into that pre-referral model, you're engaging across that whole ICB, then there's lots more stakeholders to manage and there's lots more variables. But it does offer the opportunities that you're describing insofar as can you improve access, and then you're dealing with that referral distribution problem at an earlier point in more of a prospective way rather than in post-referral, it's already happened and you're trying to correct for it. So there's lesions across all of those parts of the journey that we can support with the triage and a more appropriate urgency of management of. So yeah, that's really the aspiration is to get as early as possible and try and correct that at source. The post-market surveillance point is a really important one, and I wanted to mention it before as well. I think that's one of the aspects of market education that we've had to do actually in this. I think the notion of post-market surveillance is familiar to some people more in a medical device context, but you don't really ask it in the context of other medical devices like a blood pressure monitor or whatever. Those questions are not things that come up. But in terms of managing risk, monitoring, and knowing that it's working, that's absolutely crucial to us ensuring that we're doing what we say we do. So for us, there's a multifactorial post-market surveillance program that we have that we're really proud of and have spent a long time trying to get right. So there's straight up just the feedback that you get, whether it's direct from customers or via the regulators, and are there any trends across that? actually one part that we've not necessarily spent as much time on talking about today, but the input to the AI is actually really important. So are those images of the right lesions? So how we do audits ourselves of have the lesions been suitable when people have said these are suitable for the AI assessment. Even though there's automated image quality checks in the AI, we'll still do image quality audits on our side. And those are things that on both of them we can feed back down to the individual user level. If there's a trend that a particular image capturer has been putting through certain types of lesions when they ought not to have, we can go and feed that back directly. And then when it comes to the AI output side of things, like I said, we're always looking and monitoring at what the AI said versus what that end outcome, biopsy confirmation of cancers or biopsy confirmation of premalignants and benigns where they happened, and then clinical opinions of premalignants and benigns too. And we're always looking and comparing how the AI performed relative to that. When you're moving to and then any missed cancers, actually we'll do a root cause analysis. We've got clinical advisors of our own. We discuss those cases with the sites. If there's any themes in that can help us to deal with that on a more systematic level if we needed to. Building on that, moving on to the kind of autonomous pathway these patients are discharged, there's two things that are really important for us to monitor that. So one, we will continue to follow up on those patients after they've been discharged from our services. So if they come back through any of our services, and we've seen one instance actually where they were discharged from one of our sites, but they somehow ended up at another, and then they did end up with a cancer diagnosis, we'll follow up and find out whether that happened. So that offers a level of surveillance that standard of care is not currently achieving.
I was going to say, because that's, one of the issues you're referring to there, if between primary care and secondary care having access to that same data. I know that's not the same thing you're saying here, but this is a patient that's potentially gone to two different sites and...
The one limitation on that is that we have to be in those pathways to clock onto those. Yeah. But having said that, even a trust within and of itself, I've not seen one yet that's able to really cotton onto those proactively. It would be more a case of patients saying or complaining or making that known to those services. So that's one massive thing. We've always done that, so we know that we've got the mechanism in place to keep monitoring that way. And then one of the independent reports that I referred to, published last year, done by a group called Edge Health, commissioned by NHS England, it looked at what post-market surveillance mechanisms there ought to be in the context of autonomous AI and skin cancer pathways. One of the things they did a really good job of is sort of saying, if you were going to discharge X patients, what might a number of them being audited or reviewed by that second read step look like, that you can still confirm that it's performing at the same level that it was. So it's around about 550 cases that would otherwise be discharged will go on to audit in the context of those autonomous pathways, and that would enable us to confirm that it's still operating at the same levels that we've seen before. That's been a really important kind of statistically driven method that's really clear that we are going to continue to confirm that it's operating the way the level it needs to. But I've been able to describe that in a relative nutshell for you now, but that's also part of the journey that people need to kind of go on when they're figuring out how they're managing the risk across the pathway. And it's not the only one, that's kind of one of multiple aspects across a whole patient pathway that you can think about in terms of managing that risk. So everything from the information going out to patients before they enter the pathway and the leaflets that they might receive, through to the wording around monitoring your skin in the discharge letters that are given, are actually, there are massive opportunities in both those things, because when you're going through a typical face-to-face traditional pathway, you might just have an interaction in that 10-15 minutes with that clinician, and there are things communicated in that time frame. But I don't know about yourselves, but I'm quite nervous even as a doctor, when I go to another doctor, I don't retain all that information. So we've been forced to spend a lot of time on those external communications. We've worked with patient support groups like Melanomore in Surrey to really refine what that looks like and not overwhelm patients either. So there's a lot of opportunity actually to spend a bit more time on those things than we did before, because you've kind of relied on those other interactions or touch points to do all of that work. And we've talked about the various aspects of training and auditing as well before. And then actually importantly, in terms of that patient pathway, patients can opt out of that automated decision if they want to. It's a requirement under GDPR for specific consent for an automated decision. And so you do design your pathway in a way that, and consent, is dynamic as well. So if they do opt out at any point, they can, but we know that it's operating at the level that we need it to. That's part of like what they should get as information coming in. and then they can have that level of service when they consent.
Yeah. Once again, there's so many avenues of conversation to go from there. But I guess the point as well here with using artificial intelligence or digital tools in general in clinical practice is when people compare artificial intelligence to the performance of a dermatologist, they're comparing it to someone who's really good at what they're doing, like a professional in the field. And when you're talking about GPs as well, supporting GPs in their work who don't have the level of skill that perhaps dermatologists.
And I think it's really hard, isn't it? Because we haven't necessarily collated that data in the past, because there hasn't been anything other than going to see a dermatologist for that diagnosis. And I don't think we've been very good at collecting some of that data. So I can imagine it's been really difficult to know how sensitive and specific a consultant dermatologist is, and that will vary as well. So there's a lot of variety there. And I think it's probably important to sort of also mention sort of health inequalities, and also the fact that probably working where I do, there was a huge concern about our demographic not being digitally able, and were we actually doing more of a disservice to those patients. And so we've really tried to work with primary care, the volunteer service as well, to try and to mitigate some of that. And as I said, our referral is, do GPs think this patient's suitable for teledermatology? So hopefully that's a first level. Our fast track bookings team still make telephone conversation contact with all patients and explain the process. A patient will get a text message. So again, some don't have mobile phones. So again, that would mean that they would just come in for a face-to-face appointment. But if they have a mobile phone number, that will come to them. If they're not able to open that link and fill in their questionnaire before they come in, or look through the consent form, they then come to one of our appointments. We've got a receptionist who has an laminated consent form and information about the process. In some of our sites, we have a volunteer who's then able, with an iPad, to go through the questionnaire and guide patients through that. And I think, and then when they get in with the HCA as well, they go through the consent process again and explain the whole process. So we've really tried to sort of address each aspect of it to make sure that patients aren't being disadvantaged by the fact that this is all digitally driven. But then, we have to remember that actually some of our pensioners are actually probably more digitally able than others. So I think it's important not to make those sort of just generic statements. And increasingly, healthcare is being provided digitally, because that is part of the solution. And it's just making sure that all parts in that process, patients can have an option to maybe disengage with the digital side of things and still have that face-to-face component.
And from your perspective, can you touch on equity as well?
Yeah, I think equity is an interesting one, because obviously we need to consider it, but we need to consider it from every angle. Yeah. I think from my point of view, the question's often asked about equity in terms of the performance of the AI, which is a valid question, and we're one of the first AI companies to do one of the NHS framework for equity and health inequalities assessment. So we know that as much as the incidence of skin cancer is much lower in darker skin types, for instance, we know that there have been 44 melanomas, SCCs or BCCs in those skin types that have been assessed by the AI, and they've all been appropriately routed onto that urgent pathway. So there's no evidence that it doesn't work as well in those groups. But there are broader things to consider actually in terms of what standard of care is delivering, and I think sometimes there can be asymmetric conversations in terms of how we talk about risk as to what current standard of care has been achieving for the last decade versus basically that risk of not changing or changing now. And so we've quantified our risk really, really well in terms of knowing what's happened to all these patients. But that national data set that we look at, we know that when we talk about 1 in 3 melanomas and SCCs not being on that urgent pathway, that disproportionately affects Black and Asian patients and older patients. And so that's currently what's going on. And so we need to think about the whole pathway. And it's a good opportunity to actually think about the whole pathway as well when we go through these transformations, because yes, the AI journey is one part of that, but part of what we can achieve with that additional capacity is potentially going to enable us to address those inequities in those other groups. So yeah, and also when you think about sort of if we're going to go into the community and have these access points in the community, can we locate it closer to these patients? Can we improve their sort of awareness of their need to present to these pathways sooner because we are located closer to them? There are many determinants of sort of those sources of inequity, but I think, unfortunately, what I find far too often is that there is a sort of cursory statement made about inequity and wanting to do something about it, rather than a real drilling down into these are the subpopulations that we need to do something about, and this is the breadth of risk that is carried in those populations, rather than and that's really the only way that you can do something more about it. They're deep-rooted, long-standing problems, right? You don't just sort of say that I'm worried about inequity in this pathway and then not quantify it in order to focus your time appropriately.
I guess on the topic of equity as well, analytics seen any evidence of increasing or done any work on increasing access to regions that have less access to dermatology services, for example?
Yeah, good question. So that is very much part of the good thing about that whole EHIA framework that I described to you before is it really encourages you to go through at least 9 demographic factors. You can do additional ones, and we have, but you'll look at what the risks and benefits posed by your technology are. Mm-hmm. But importantly, you'll look at what that next step could be in terms of what you could do about it, and that's not exclusive to us as a technology provider. There are collaborative components in that we have to think about because we're not in control of all steps of that patient journey. So that increased access, actually, a lot of it, the biggest opportunities, as we sort of described, of what are those access points in the community. So making them closer to home, I think, is a massive one. And that's why that pre-referral vision is very much there, and we want to do that. But equally, you can't sort of, you still need to be able to deploy something that's of value now. So that's why a lot of the sites that we've worked with have historically gone for that post-referral model, and it's much more easier to contain. But then there can be, as much as we sort of want to be able to deploy and could deploy across all of those different locations, things like staffing, what estates are available to those sites that we work with, those are massive variables that determine how much we can do that. So that's something that we make available to it's actually a summary of it's available on our website, but we make that proactively available to any prospective partner that we're going to work with a view to encouraging thinking along those lines.
Do you have anything to add?
No, I've still got my dreams of a little van and driving around, having pictures taken everywhere. Because I think certainly more west,
like a mobile.
Yeah,
that would
west of our county, it's a long drive to a hospital.
Yeah.
And certainly you've got areas in Scotland, etc., where it's a long drive to a dermatologist. So if we could have these image capture hubs mobile and going out to patients, I think that increases accessibility, and then that's when it has that impact on not only increasing our detection of skin cancer at early stages, which is essentially what we need as a population, but it also has the huge impact on hopefully our referrals and seeing the right people. But that's yet to be seen. We endorse it. We know what impact this has on a biased population of already referred patients, and there is definite skepticism and concern about if we open this out to everybody who's phoned the receptionist and has a skin growth, so they haven't been seen by anybody and haven't been filtered out by anybody. What impact does that actually have on our referral rates? Does it increase? But it's always a balance, isn't it? A balance about detecting melanoma, SCC at earlier stages, so patients don't have significant disease by the time they get to us, but also trying to meet the capacity and have the capacity demand model better.
Back to you. It's a question looking into the future of how far can you go, because I guess perhaps the ultimate goal would be to have access to this from their phones. If people could do it from their phones, that would be amazing. But I'm sure as many people dermatologists know, that's not realistic at this point. There's, especially with AI, there's many intricacies about even subtle differences in cameras on phones, and you need an access to a dermoscope. But thinking of that potentially down the line, what does the future potentially hold for this technology?
I mean, there's going to be people with different views on this, so I wouldn't say I necessarily speak for the company on this one, but I do think that general trend of let's try and get that access as close to home as possible. Yeah, right now that dermoscopic attachment is required, but it might be that you could have a patient journey that starts off with their own image capture at home, doesn't need that, and that's kind of a triage before the dermoscopic triage as required. So I think there's lots of opportunities there, and yeah, we've talked a lot about access, and that's what you'd love to see happen, actually, patients being able to have that earliest opportunity for that assessment. I think that there are lots of challenges to overcome in making that possible, though, because with every increase, like with every step change and increase to access, there's also a broader remit of things that you need to keep your eye on. And so, in the context of even surveillance, for instance, when those patients have access to it at home, one, they need a connected opportunity to get into the services that they need to, should it be a high risk thing, and have that timely access. Otherwise, we're not really getting to that point of earlier detection of skin cancer. We're just sort of giving people outputs. And I've had a journey like that myself, which I can talk about later maybe. Not with our tech, but otherwise. So I think that's probably there are intricacies like that we need to work through, but that's kind of the best version of it, I think, where you give every patient the kind of opportunity to access the most timely care that they could, according to what they're comfortable using technology-wise. I think a lot of what I've learned in that sort of deployment journey has been you need to make sure that those avenues are open to the right groups of patients, and there's always going to be a subset who, for clinical reasons, need to be seen face-to-face, and you'll always make a route for them as frictionless as possible. But equally, we don't want to stem the tide of innovation that's actually going to create capacity for us. And so we need to take advantage of all of those opportunities without creating a sort of proliferation of standards along the way.
Yeah, of course. And I will emphasize that is a very rose tinted. I'm not suggesting that that's, where things have to go. It's just looking into the future, I think a lot of people would agree that patient empowerment is, a lot of where care.
Yeah, I mean, there is technology out there that patients are using for mole surveillance and for looking at moles, determining whether they need to go and see their GP. But I think it comes down to, at the moment, it's lovely to dream, and absolutely we want these things to empower patients. But right now it's being clear on the problem that needs the solution to enable better healthcare for all. And right now it is I feel that we need technology to help us with the capacity issue right now.
And how do you think about, because you mentioned earlier, and it's also a very turbulent time for the NHS and funding in general, how do you feel that you're going to be navigating that in the coming?
Yeah, I guess I come from a position where at the end of the day I'm the patient advocate and I want the best for my patients, and I like to try and separate myself from some of those financial decisions, and there are people who are paid to do that, but clearly it has to be a conversation between those with the purse strings and those of us on the ground. I am clearly keen to try and see where the future lies with these sort of digitally enabled pathways, because I do think there is huge potential for improvement in my population's dermatology care through using these pathways. I think it's quite early days. Clearly there was recently a decision to make huge changes with NHSE being dissolved. And we wait to see exactly what impact that has. Certainly already I know that huge cuts are being made in the commissioning abilities. So just prior to that decision, I had potential agreement for a 6-month extension of our pilot whilst we try and integrate this into a pre-referral integrated pathway. And I don't know whether that still stands as it is today. So it is a really uncertain time. It's a frustrating time as well, because you spend a lot of time going to various meetings, wanting these decisions to be made. And then to feel like you've got to go through those discussions again can be very frustrating, because at the end of the day, I want to be seeing patients and I want to be doing the thing that I'm skilled to do. And I want to be seeing improvements in the service that I'm providing. And so, yes, it is very frustrating. It's a really uncertain time. I really, really hope, though, that as a dermatology group, so as the British Association of Dermatologists, although there is absolute caution with this, which is totally appropriate, I really hope that as a body we can really start to embrace new technologies and how that can improve the services for our patients. And the slogan of the British Association of Dermatologists is healthy skin for all. And I really think that we need to be looking into how we can be integrating AI, derm as a medical device, all of these things into improving the healthcare for our dermatology patients.
Yeah, and to finish off, what about the future for skin analytics?
Good question. It's a really exciting time for us. I think we've done some amazing work with some amazing people over the last few years in the UK, and I actually think we don't often credit that enough for how world leading that is. Like even if you go stateside, they're kind of, they'll use LLMs a bit more in their day-to-day practice, but actually from an AI diagnostics point of view, we were out at a conference at the same time in America. They're not as forward thinking, and they haven't done as much work in that domain as we have out here. So I think we really need to give ourselves a pat on the back for making changes that are going to improve those overall pathways, leveraging tools like this to the maximum effect. Actually, if you sort of said, can we actually create that much capacity with a particular technology being integrated in this pathway? I'm not sure that, there's that many solutions that have been tried over the last decade. I can imagine a lot of people felt disillusioned that there wasn't going to be a potential step change like that. So, and now we're at the juncture in the UK where there are sites using it autonomously. I think that needs to become the norm here in order to maximize the benefits of what we do. We've seen over 5 years of deployment now that it's operating at the level that it needs to. And at this stage, although I appreciate and understand the desire to minimize or completely mitigate risk already exists in that, and the more you sort of divert dermatologists' capacity to that additional work that they didn't need to do, the more you're compromising the ability to get to those other skin cancer patients as quickly as you need to when they're on the wrong pathway, or to make time for the inflammatory patients that need to be seen to. So that really is, I think, the most immediate next step at home. We've got our CE Class 3 marking now, so it's very much about trying to expand that impact into other countries and see that we can support healthcare systems in the same sort of way.
And just quickly as well, are there any lessons that you've learnt from other countries or other deployments that...
From other countries of deployments of DAM, that's still kind of in the offing. So I think one of the big things with healthcare systems in general, I think, is that they all vary in their construct and their sort of where they sit on the public versus private spectrum. And that interplay between payers and providers varies because of that. And aligning all incentives towards actual just better patient outcomes is really difficult. Here we've got a system that is scarcely resourced, and so we're focused on cost effectiveness. And so we have limited budget within which to deliver the best possible quality of care that we can, and we do an extraordinary job of doing that. And so it makes natural sense that everything's focused on, can we just make Alice's time better spent? In other systems, it's not quite as obvious how that incentive will align to focus on that better patient outcome. And so there will be some interesting challenges in that framing. But either way, I think the broad principle of what AI can enable us to do in these contexts, and really what I see the value of it is being that prioritization, making sure the right people are seen by the right person in a timely fashion. And I think what that offers us an opportunity for, that I think kind of pushed me away from practicing in a lot of ways, is that we can have continuity of care potentially again. Like, the thing that I valued most on the ground was an additional minute or two that I took with a patient just to listen to them more than someone else had. And you don't get that now because you're firefighting on the ground. So that, I think, is really what this ability to prioritize patient risk better will enable us to do. So yeah, let's keep building towards that.
Is there anything else that you guys would like to touch on?
Yeah, so it's pretty unique in a healthcare circumstance, I think, that you might have gone through a similar journey that your patient might have, or that the domain in which you're working, you've got some sort of patient experience to lean on as well. So I had a mole on my back that looked a bit dodgy, had experience of like family members saying, that looks a bit weird, are you sure you don't want to get that checked? I think sometimes when you're a doctor as well, you sort of put it off thinking, I know best, you don't need to worry about me. Put it off for a while, and then, because I honestly just felt like GP waiting times might be too long, so I just took an image of it, uploaded it to some random AI on the internet, got 5 possible diagnoses back, and an opportunity to, I don't know, I think it was pay $30 for a dermatologist review. But it was for me as an experience as a patient at that time, it was like a proliferation of options, or it didn't really help me determine what my next step is. So coming into the role that I'm in now and seeing how we approach it, where there is a definite next step for a patient and it's not a disconnected journey, is something that I really valued a lot in this context. But even going through that kind of face-to-face dermatologist appointment when it eventually happened, it was sort of, I was offered a skin check, felt too nervous about the thing, so I didn't have it. I had a registrar review me, and then a consultant come into the room because they weren't sure. And the consultant sort of just looked at my mole with a dermoscope and said, yeah, we'll take it out, and then left the room. And I didn't really, it's quite a lot to be told you're going to have an operation just in a snapshot statement of about 3 words. Yeah. So I think there isn't, like, we talk about it, but in passing, but there's an untold story about how much patient anxiety is on this pathway, waiting to be told that you don't have cancer, and how much more opportunity there is for us to do that. And health economics tries to do its way of quantifying that, but I don't think we necessarily perceive it in the way that is completely balanced. So yeah, that is a risk too, that we're sort of, there are biopsies of benign lesions that are happening that could be avoided, and with the AI in the pathway, we know that there's an opportunity to do that. But also that anxiety element, we can shorten that time frame down by quite a lot, because that initial AI assessment might be able to come sooner. So I think those are massive opportunities just from an individual patient journey perspective that I've seen from that I'm quite excited to realise more in the role that I have now.
And I think probably a lot of the information that we're now giving to patients is better, because we've got standardised letters that go to patients, which includes a lot of patient information about surgery, about their diagnosis, etc. And I think it was very variable previously as to how much information patients were getting. We've got excellent BAD patient information leaflets, and we now know that every patient that goes through the teledermatology pathway will get referenced to that. Every patient that goes through will get a patient information leaflet about the surgery they're about to have. Whereas I think that didn't always happen in the past. So arguably, some of the information that's being given is better. And as you alluded to earlier, when you're in that consultation, you don't take on very much. But now you're getting it as a letter, and you're getting it in a time where you can process it in your own way. So it'd be interesting to know how much of an impact that has.
Yeah, for sure.
Well, thanks very much, guys. Appreciate your time.